The Bridging Barriers to Newcomer Mental Health was designed early in 2018 and pivoted under COVID to meet an increasing need and provide initial mental health support for newcomers in the Niagara region that experience language and other social barriers to accessing mainstream mental health support prior to and during COVID-19. The impetus for developing this promising practice was threefold: the restrictions imposed due to COVID-19 and the disproportionate impact that it had on newcomers and all members of equity-deserving groups, the pre-existing stigma around mental health for immigrants and refugees, as well as the systemic gaps and barriers to accessing healthcare as it relates to mental health. The program is made up of 5 components: one-on-one counseling, which turned to virtual during COVID when there was a shutdown, but in person mostly where it was possible, a mental health chat line, offering also group sessions that are inclusive with an art therapy program, as well as an anti-stigma education and an educational video series campaign titled "From Someone Like Me, for Someone Like Me." And this series has allowed for our mental health counselors, as well as staff with lived experience, to deliver messages to clients in their first language about the importance of seeking mental health support and the impact that it can have on their settlement journeys. Our client groups are newcomers, either permanent residents, landed immigrants, intent to land, approved permanent resident applicants, convention refugees, or lived-in caregivers. Those are individuals who are able to access both our one-on-one and in-person online supports. And in addition, the chat line and the educational programming are available to all newcomers regardless of status. Individuals who are not eligible for our programs are still seen one time and referred to other programs as appropriate. The 4 primary languages would be English, Arabic, Mandarin, and Spanish in first language. And if interpretation is needed, then we have 14 additional languages that we can tap into inside our building.
The key features that contribute to this program's effectiveness, I would say first one is our services are provided in the client's first language. It's welcomed by clients not only because language is sometimes a communication barrier, but also because using first language makes it much easier to express mental health concerns for our clients and much easier to strengthen the therapeutic relationship. The second factor, I would say, our anti-stigma campaigns, including presentations, mini orientations in many events, and educational videos, had a significant impact on client uptake, breaking barriers and normalizing conversations about mental health. The third feature, I would say, we gave increased connections to support for newcomers by introducing culturally informed social support programs and activities, and our services are provided in a community-based space. This helped a lot to reduce clients' fear and worry compared to institution-based space. Normally, some of our clients they have concerns or worries when they see uniformed authorities or when they have to go to institutions, for example, hospitals or police stations. But our services are provided in our settlement agency. So our clients are familiar with our agency, familiar with all the staff members. So it's more comfortable for them to come to talk to us.
In terms of the mental health services referral pathway, when newcomers come to us and identify either a service need in health or mental health, the first place they will access is our Welcome Center, where the intake and the assessment happens. They would be referred to the mental health support services. So they would go first to the mental health navigator. And this mental health navigator, the role of this person is to do a basic triage. So the triage would be does this individual need external long-term medical mental health services that we cannot offer? Is this a crisis support service request? Or is it something that we at the center can provide by ongoing one-on-one counseling and social support activities? And once the settlement service element has been identified, then of course the individual would go to our settlement department and receive what I would call the traditional settlement support, such as community connections, ESL, job search supports, mentorship. And of course, once they have received and obtained all of the available services with us, then the role of the navigator would also be equally important to support the exit strategy. And this exit strategy is already started from the beginning. So this is why the thorough intake and assessment is so important, so that we know what the exit strategy will be like or what the outcome will look like for every individual. Key partners in the Bridging Barriers to the Mental Health program are definitely the settlement sector. We work very collaboratively with other partners so that there's a referral path from other organizations to us. Of course, another key partner is the health sector itself. So for instance, family health teams, the local community health center we have partnered with, as well as creating a pilot program where there's a mobile health team that is able to provide primary care support as well as mental health support. And of course, the acute health supports within the hospital system, whether that's through Emerge or Psych Emerge. Those are all key partners that you have to engage with. We have also benefited from a great collaboration with our local public health team units as it relates to advocating for social determinants of health factors and how we collectively can support that, not only with our campaign, which is an education campaign, but also the anti-stigma campaign. We have also partnered with organizations such as Positive Living Niagara, who are able to support services to migrant workers or individuals without status, so that when we have a situation where we are not able to provide ongoing service to someone, we have a touch point and another partner who can step in and provide the critical services without ethically compromising the integrity of the process.
This program has allowed us to uncover additional challenges faced by clients, such as domestic, family, and gender-based violence. And we have responded to this additional needs by catering support services to address them and actively educating our staff to be champions. An example of this is that one of our staff members attended a training provided by IRCC and has taken on the role of peer champion for the Immigrant and Refugee Committee to end domestic violence. That's a big deal for all of our clients.
In our first year of the project, we served over 400 clients. We have successfully served over 201 clients in one-on-one counseling sessions virtually, and 286 clients either through the chat line or through accessing our educational resources. It is a very significant number if you count from July. It's less than 10 months of a time span. Being able to connect with 201 clients for an over 1 hour session virtually for mental health, we found that pretty significant compared to what other people were reporting. We have the webpage that has all the resources for mental health on it. So the chat line, the videos, that page on its own, up until February, had 8,000 hits. So it just shows that people are interested, they're accessing, even if they're not specifically coming forward for the one-on-one service, they're still accessing the other resources. They're still looking for help. We also have outreach from other agencies that come to us to say that we have clients that don't speak this language, that are like presenting with mental health challenges, or their children are presenting with mental health challenges. Can you support us? So it's almost like we've become the reference point with regards to this program in Niagara. And I'm not surprised, because we are the only program that only focuses on newcomers and immigrant mental health. We're also very keen on data collection and tracking different information. So we have our OCMS system, which is our client management system created by OCASI, which is very helpful in collecting information and feeding us reports. But we also have created our own tracking system where we track very detailed information about clients, of course, when they're willing to provide it. So their name, their age, which country they're from, their history. We allow clients to identify their main concerns, as many as they want. For example, one of them is stress management. Another one is suicidal thoughts. Another one is family back home. Factors that they've brought to us, very relevant, and that we found are common across different clients. When we have that information, we correlate it with things like immigration status. So for example, stress management was the highest main concern for clients who are still refugee claimants. We implemented a depression scale and an anxiety scale as well. We obviously aren't clinical. We weren't clinical. It's a community-based service, but we use those as a baseline to identify where clients are starting and what progress they were making and allowing them. So it was questions like rate yourself, for example, how often do you feel sad? How often do you cry? And then we would repeat those in every session and see if there was progress. We also had students assessing clients during social support activities, whether it was art therapy or music therapy or the support groups. We've gotten a lot of positive feedback from clients about how much the program has helped them, how important it is that we have been responsive to their needs.
I think it's more difficult to say the client, we need to stop here because, for example, we have the maximum of this amount of sessions. It's more difficult to say bye than to keep them. The need is there. Clients and especially newcomers, they need to talk and they reach out to find someone. We need to consider that most of the newcomers, they have two main things: post-traumatic stress disorders. The treatment for post-traumatic stress disorder is a very long treatment. And second reason that we assist is transition process, the immigration grief. And that is also a process to understand. So retention is not a problem for us. It's more like how to say, okay, you're ready to go. You're ready to continue. But we are fortunate to have a very responsive team and many ways to reach out to them. I think all those strategies help the clients to stay motivated and to continue finding ways to heal.
And I think the most important element that you would want to provide, whether you're in a small place or a large one, is the ability to provide the online chat line, because that allows the smallest organizations to still provide some sort of connectability and at the same time provide anonymity to individuals who may not be ready yet to see somebody in person. So I think the best way to do this is to take the components of the model and see which of them can be adopted based on, what I would call sample size or population size. But if you had to sort of choose between the components, I would say number one, keep the chat line first and foremost. And then if and where possible, add on the one-on-one supports, add on the recreation opportunities, and of course, add on, the group art therapy or any kind of supports that you have. So, and again, to manage the chat line in an ethical manner when we don't have the social workers on site has also been very important. And I think that's another key human resource element that anyone wanting to take this program on needs to consider. And the way we solved it is we connected with a co-op intern program within the university where social work interns are actually managing our chat line for us when they're not there. We also ensured that every partner was thoroughly involved in our evaluation plan. We were co-creators and collaborators. We had a very clear referral program to and from within our services. We have a clear crisis response in terms of what are the things that our case managers are able to handle within our organization and what falls out of scope. And that helped us to be very mindful of building collaborative relationships with our health partners and mental health partners, both in the community and in acute settings, so that we have a clear soft transfer between us and other organizations, and a clear starting point and a stopping point, so that individuals can continue to migrate through our systems and have a clear exit plan from the beginning when the journey starts. So I think those would be, I would think, key partnership factors that anyone thinking about replicating this model in other parts of the country or in other provinces would need to take into account. We can already see that this model can be adopted and replicated, and the next step we want to do is create a similar model for clients who are leaving domestic and family and gender-based violence issues. So for us, the impact of the pilot allowed us to see the potential to support other issues that are not easy to tackle and support within our community.
Our findings also allowed us to be able to come up with a set of recommendations to share, but also that we continue to follow as we evolve our program. And there are 5 of them. So the first is supporting approaches to promoting migrant well-being across systems. So not just limiting mental health to mental health, and not just limiting education to education, but working together with health, social services, settlement, and education, through developing, enhancing, and coordinating partnerships, so that we're feeding each other knowledge, we're feeding each other information, and we're working like a well-oiled machine, right? So that there aren't gaps that clients are facing when being moved or referred from one service to another. Another is supporting like integrated community-based mental health services. So not just institutional, not just clinical services, but the importance of community-based mental health services that address social determinants of migrant mental health, that are gender, life stage, identity, culturally sensitive, and that recognize both the challenges and the resiliences of diverse groups. Another recommendation that we have come up with is supporting education and training towards public education and campaigns that are directed at diverse groups of migrants. So large-scale anti-stigma campaigns that are on commercials, that are on social media, to be translated into different languages so that clients are actually understanding them. And not only anti-stigma campaigns, but also knowledge exchange and education around what services exist and exactly how to access them in first language. And also education to health and social service providers and students about culturally competent mental health care and culturally sensitive activities and programming. Our final 2 recommendations are supporting policies that remove barriers to economic and social integration of newcomers. Our last one is supporting longitudinal and comparative research of migrant mental health that considers multiple determinants of well-being.